Hello everyone, welcome in SS Medical Classes. Myself, Dr. Nirbhay Singh from Government Medical College, Kota, Rajasthan. Today we will talk about a very important topic. It is HIV/AIDS, which is very important for our university examination, in NEET PG examinations, and INICET examination. So let's continue with the topic. So let's start discussing the HIV/AIDS. The full form of HIV is human immunodeficiency virus, and it causes a disease which is known as AIDS. AIDS means acquired immunodeficiency syndrome. मतलब जैसा कि इसके वर्डिंग में आ रहा है, इट इज़ एक्वायर्ड एंड इट इज़ इम्यूनोडिफिशियंसी सिंड्रोम. इसमें इम्यून सिस्टम की डिफिशियंसी हो जाती है, जिसकी वजह से हमें बहुत सारी डिजीज़ेज हो जाती है. So let's start with the introduction. The HIV virus belongs to the family Retroviridae. Now, what are retroviruses? Viruses which belong to the family Retroviridae are known as retroviruses. Now, retroviruses are a group of RNA viruses that possess a unique enzyme called reverse transcriptase, which direct the synthesis of DNA from the viral RNA. जनरली हमारे ट्रांसक्रिप्शन में क्या होता है कि जो DNA है उससे हमारा mRNA बनता है, ठीक है ना, तो फिर वो होता है ट्रांसक्रिप्शन. बट इन दीज वायरसेस देयर इज अ एंजाइम कॉल्ड रिवर्स ट्रांसक्रिप्टेज विच डायरेक्ट्स द सिंथेसिस ऑफ DNA फ्रॉम द वायरल RNA. तो इसलिए इनको कहते हैं रेट्रोवायरसेस. दे पोजेस अ यूनिक एंजाइम का रिवर्स ट्रांसक्रिप्टेज, जो कि क्या करते हैं, सिंथेसिस ऑफ DNA फ्रॉम द वायरल RNA. ये RNA से DNA बनाते हैं. तो जो हमारा HIV है वो भी इसी ग्रुप का वायरस है, विच इज़ अ रेट्रोवायरस विच एंड बिलोंग्स टू द फैमिली रेट्रोवायरिडी. अगर जीनस की हम बात करें तो इट बिलोंग्स टू द जीनस लेंटिवायरस. तो फैमिली हो गई रेट्रोवायरिडी, जीनस हो गया लेंटिवायरस. अब इस जीनस में हमारे दोनों सीरोटाइप्स आ जाते हैं. HIV के दो सीरोटाइप्स हैं, HIV1 एंड HIV2. So as you can see, this is a diagram of HIV virus. From it can be seen that HIV is a capsulated virus. It is a capsulated virus, and the structure of HIV virus is composed of two parts. First one is envelope, and the second one is nucleocapsid. So this envelope part of the HIV virus is made up of two parts, which is first the lipid part and the other is the protein part. तो जी HIV का जो स्ट्रक्चर है, इसमें एनवलप होता है, न्यूक्लियोकैप्सिड होता है. अभी एनवलप हमारा दो चीज़ों से मिलकर बनता है, एक तो लिपिड और एक प्रोटीन. अब आप इस स्ट्रक्चर में जैसा कि देख सकते हैं कि ये जो है ये हमारा एनवलप है. अब ये है लिपिड, ये लिपिड की लेयर है ना, ये जो ग्रीन से मार्क करी ये लिपिड की लेयर है. अब इसमें जो प्रोटीन पार्ट है, प्रोटीन पार्ट किससे मिलके बना होता है, मेडअप ऑफ टू ग्लाइकोप्रोटीन्स, GP120 इट इज़ ग्लाइकोप्रोटीन 120 एंड GP41 इट इज़ ग्लाइकोप्रोटीन 41. एज यू कैन सी GP120 एंड GP41. नाउ GP120 कैसी होती है, इट इज़ नॉब लाइक. It is knob-like and projects outside the lipid layer. And GP41, as you can see, it is embedded in the lipid layer. So two protein, that is GP120, glycoprotein 120 and glycoprotein 41. So envelope is made up of two parts. It is lipid and the protein. The lipid layer, you can see that I marked with the green color. This is the lipid layer. And the protein part is composed of two glycoproteins, that is glycoprotein 120 and glycoprotein 41. Now the nucleocapsid. As you can see the structure of HIV, this nucleocapsid is icosahedral in symmetry. Now the symmetry of the HIV virus is icosahedral. Its nucleocapsid is icosahedral in symmetry. Now, as you can see in this diagram, it is a core. It is a core of HIV virus, and this layer present inner to the lipid layer is matrix. Now inside the core, there are present two molecules of single-stranded linear positive sense RNA. Two molecules of single-strand linear positive sense RNA having the enzyme associated with them is reverse transcriptase. So this is the structure of HIV virus. So it is composed of two parts. It is envelope and the nucleocapsid. Envelope is composed of two parts. It is the lipid part, the lipid layer which we have seen, the protein part which is composed of two components. It is glycoprotein 120 and glycoprotein 41. Glycoprotein 120 is a knob-like, glycoprotein 41 is embedded in the lipid layer. It is straight rod-like structure. And the nucleocapsid is icosahedral in symmetry. And the RNA, two identical copies of single-stranded positive sense linear RNA. The RNA is of positive sense and there are two identical copies, not single, it is two identical copies of single-stranded positive sense and linear RNA, which have in association have viral enzymes such as reverse transcriptase, integrase and proteases. So mainly three enzymes are present, that is reverse transcriptase and integrase and proteases. So this is the structure of HIV virus. Now let's talk about the HIV genes and antigens. So there are two types of genes, structural genes and non-structural or regulatory genes. So structural genes, there are three structural genes which are GAG, POL and N. GAG, POL and N. These are three structural genes and there are six non-structural or regulatory genes. So GAG, POL and N. These are three structural genes and other six are non-structural or regulatory genes. So let's talk about the structural genes. The GAG genes code for the core and shell of the virus. So the GAG is a structural genes which codes for the core and the shell of the virus. Now it is expressed as precursor protein P55. ये जो है सबसे पहले प्रीकर्सर प्रोटीन के फॉर्म में एक्सप्रेस होता है, फिर बाद में ये जो P55 प्रोटीन है क्लीव्स इनटू थ्री प्रोटीन्स, दैट इज P18, P24 and P15. Now P18 constitute the matrix or shell antigen and P24 and P15 constitute the core antigen. So the GAG gene codes for the core and the shell of the virus and it is expressed as precursor protein P55. This P55 protein is cleaved into other three proteins which are P18, P24 and P15. Now P18 constitute the matrix or the shell and P24 and P15 together constitute the core antigens. Now the second gene is POL gene. So three genes, GAG gene जो कि हमने देख लिया, GAG gene इसके बारे में पढ़ लिया. Now second one is POL gene. POL gene codes for the viral enzyme such as reverse transcriptase, protease and integrase. So in HIV, three main enzymes are present in HIV virus: reverse transcriptase, protease and integrase. So these are coded by the POL gene. Now this POL gene is also expressed as a precursor protein which is cleaved into proteins P31, P51 and P66. Now the P31 codes for the integrase and the P51 codes for the reverse transcriptase. Now the third structural gene is the NV gene. as the N gene codes for the enveloped glycoprotein GP160, which is cleaved into two components GP120 and GP41. Now in the word N, as you can see, the envelope is coming ENV. Now in the word N gene codes for the enveloped glycoprotein. Now this enveloped glycoprotein is form of GP120, which is cleaved into the two components, that is GP120 and the GP41. Which GP120, which we have seen in the structure of HIV, is a knob-like glycoprotein which projects outside the lipid layer. This is the GP120, which is coded by the N gene. Now GP120 is the main receptor of HIV that binds to CD4 molecules on host cell. Now this glycoprotein 120 GP120 is the main receptor HIV. ये HIV का मेन रिसेप्टर है जो कि CD4 मॉलिक्यूल, जो कि होस्ट सेल के सरफेस पे CD4 मॉलिक्यूल रिसेप्टर प्रेजेंट होता है, उससे ये GP121 ही जाके बाइंड करता है। जब HIV हमारे होस्ट सेल पे अटैच होगा तो विद द हेल्प ऑफ GP120 ये बाइंड करेगा CD4 molecules present on the host cell. So it is the main receptor that HIV binds to CD4 molecules on host cell. And GP41, it is a fusion protein. So these two proteins, the N gene codes for the envelope. Now the 6 are the non-structural genes or regulatory genes. Now we can divide it into two parts: essential regulatory genes and accessory regulatory genes. Now essential regulatory genes are TET, NEF and REV. TET means transcriptional transactivator, NEF means negative factor, and the REV. Third one is REV gene. Now three essential regulatory genes are present: TET, NEF and REV. And the accessory regulatory genes. First is VIF, the viral infectivity factor, the VPR and the VPU. So these all are non-structural genes. 6 are non-structural genes and 3 are structural genes. Structural genes GAG, POL and INV. And non-structural genes are essential regulatory genes and accessory regulatory genes. Now let's come to the pathogenesis of the HIV virus. In pathogenesis, first let's discuss the mode of transmission. So mode of transmission of HIV virus is, first if we talk about it, is sexual, through blood products. Second one is through blood products. Third one is percutaneous or mucosal, or the fourth one is perinatal. Perinatal means from mother to fetus. It is known as perinatal mode of transmission. So these are the 4 common mode of transmission of HIV virus. So the sexual mode. Second one is blood products. Third is percutaneous or mucosal. For example, in percutaneous or mucosal means needle stuck injury or splashes of blood of an infected HIV patient into the eyes of a doctor or sometimes during operating. Then it is a percutaneous or mucosal mode of transmission. Now perinatal, from mother to fetus. Transmission, we have talked about 4 main modes of transmission: sexual mode, blood products, percutaneous or mucosal, or through perinatal, it is from mother to fetus. Now you can see in this table there are routes of transmission given, risk of transmission and percentage of total transmission. Now the risk of transmission through blood transfusion is maximum, that is 90%. More than 90% risk of transmission is through blood products. But how many cases, a percentage of total transmission observed, and number of that is the percentage of total transmission is 5% and 1% in India. Now parent to child, that is during, it is a prenatal mode of transmission from mother to fetus. The risk of transmission is 13 to 40% and the percentage of total transmission is 10%. Now through sexual intercourse, It is a through sexual intercourse. The percentage of total transmission is maximum. That is 75%. It is the most common mode of transmission, but the risk is less. Here you can see 0.1 to 1%. The most common mode of transmission is sexual, through sexual intercourse or sexual mode, but the risk is less, 0.1 to 1%. And the risk of transmission is maximum in blood products, that is blood transfusion. अब इन सेक्सुअल इंटरकोर्स में भी 3 टाइप्स हैं. फॉर एग्जाम्पल वेजाइनल, थ्रू द एनल और ओरल सेक्सुअल इंटरकोर्स. नाउ the risk of transmission through anal intercourse is greater than the vaginal intercourse. As you can see, it is the percentage given 0.5 up to 0.5%, but the percentage of total transmission takes place maximally in vaginal sexual intercourse, that is heterosexual mode of transmission. Heterosexual mode, 60% of the transmission takes place through heterosexual mode of transmission. Or through the injection drug abuse. Now in IV drug abusers, आपने देखा होगा कि इंजेक्शन अगर बिना स्टेराइल करे या न्यू इंजेक्शन या सेम इंजेक्शन अगर यूज़ करते हैं IV ड्रग यूज़र्स, तो उस केस में भी HIV का ट्रांसमिशन होता है. तो इन दिस केस द रिस्क ऑफ ट्रांसमिशन इज 0.5 to 1% एंड द परसेंटेज ऑफ टोटल ट्रांसमिशन इज 10%. इन नीडल स्टिक एक्सपोजर द रिस्क ऑफ ट्रांसमिशन इज 0.3% एंड the percentage of total transmission is 0.1%. So most common mode of transmission of HIV is sexual. उसमें भी heterosexual means vaginal through male or female, and the maximum risk of transmission is in more than 90% in blood products. In case of mother to fetus or perinatal mode of transmission, the risk of transmission is 13 to 40%. And 10% total transmission occurs. So perinatal mode, it is in the absence of any intervention. The risk transmission from mother to fetus is about 20 to 40% in the absence of any intervention. And transmission may occur at any time during pregnancy and breastfeeding. Breastfeeding और pregnancy के दौरान कभी भी transmission हो सकता है, but the risk is maximum during delivery. During the delivery, the chances and the risk of transmission of HIV virus from mother to fetus is maximum. However, it can be transmitted during pregnancy or breastfeeding, but the risk is maximum during delivery. And the risk is maximum if mother is recently infected or already developed AIDS. अगर किसी मदर को रिसेंटली एड्स से इन्फेक्शन हुआ है और ऑलरेडी वो एड्स में डेवलप हो गई है, मीन्स उनकी जो डिजीज़ है वो ऑलरेडी प्रोग्रेस हो चुकी है एड्स की, मतलब CD4 काउंट इतना कम हो चुका है लेस देन 200 की वो एड्स डिजीज़ डेवलप हो चुकी है. सो द रिस्क इज़ मैक्सिमम इन द फीटस इफ मदर इज रिसेंटली इन्फेक्टेड और हैज ऑलरेडी डेवलप्ड एड्स. नाउ सम पॉइंट्स. There is no evidence of HIV transmission by casual contact or kissing or insect bite. मतलब अभी तक इसका एविडेंस मिला नहीं है कि HIV ट्रांसमिशन कैजुअल कांटेक्ट से हो सकता है. मीन्स आप किसी से हाथ मिला रहे हैं, किसी से गले मिल रहे हैं, तो आपको ऐसा नहीं है कि HIV हो जाएगा. ऐसा कोई एविडेंस अभी नहीं मिला है. थ्रू किसिंग का भी अभी कोई एविडेंस नहीं मिला है. एंड नॉट थ्रू द इंसेक्ट बाइट. थ्रू मॉस्किटो बाइट, एक मच्छर, किसी ने HIV पेशेंट को एक मच्छर ने काटा, फिर वही में अगर मॉस्किटो हमें बाइट कर लेता तो उससे HIV ट्रांसमिट नहीं होता. देयर इज़ नो एविडेंस ऑफ HIV ट्रांसमिशन. Now the viral load is maximum in blood and genital secretion and CSF. अब वायरल लोड सबसे ज़्यादा कहाँ पे होता है? ब्लड में होगा, जेनाइटल सिक्रेशंस में होगा एंड सेरेब्रोस्पाइनल फ्लूइड में होगा. एंड इट इज़ वेरिएबल इन ब्रेस्ट मिल्क एंड सलाइवा एंड 0 to मिनिमल इन अदर बॉडी फ्लूइड्स और यूरिन. ब्रेस्ट मिल्क एंड सलाइवा में ये वेरिएबल क्वांटिटी में होगा. मतलब वायरल लोड इतना भी कम होता है कभी कभी कि हो, जैसे कि क्या पता उससे ट्रांसमिशन ना हो. जैसे मॉस्किटो बाइट में ही है कि ट्रांसमिशन नहीं होता. So it is variable in breast milk and saliva and 0 to minimal in other body fluids or urine. Saliva may contain inhibitory substances like fibronectin and glycoprotein which prevent transmission of the virus. सलाइवा में हमारे कुछ इनहिबिटरी सब्सटेंस होते हैं, फॉर एग्जांपल फाइब्रोनेक्टिन एंड ग्लाइकोप्रोटीन विच प्रिवेंट्स द ट्रांसमिशन ऑफ वायरस. अब ऐसा कि देखें हमने नो एविडेंस ऑफ HIV ट्रांसमिशन बाई किसिंग, सो इट कैन बी अ explanation of this that saliva may contain inhibitory substances, for example fibronectin and glycoprotein which prevents the transmission of the virus. Now receptor attachment, as we have discussed that glycoprotein 120 which is present in the envelope knob like structure, it is the main glycoprotein which attaches to the CD4 receptors on host cell. So receptor attachment, main receptor HIV enters into the target cell by binding its वो अपना जो उसमें स्ट्रक्चर में उसका ग्लाइकोप्रोटीन 120 होता है उसको किससे बाइंड करता है, तो CD4 receptors on host cell surface. Means HIV enters into the target cell by binding its GP120 into the host CD4 receptor. होस्ट सेल CD4 रिसेप्टर, तो HIV ऐसे होस्ट सेल से बाइंड हो जाता है. नाउ CD4 molecules are mainly expressed on helper T cells and also on the surface of various other cells like monocyte, macrophages. अब HIV वायरस जाके CD4 molecules में होस्ट सेल के उससे बाइंड हो जाता है थ्रू ग्लाइकोप्रोटीन 120. अब ये जो CD4 रिसेप्टर्स हैं कहाँ कौन सी होस्ट सेल्स में होते हैं, for example in helper T cells and also on the surface of various other cells like monocyte or macrophages. Important point is a second co-receptor in addition to CD4 is necessary for fusion of HIV to gain entry into the host cell. एक सेकेंडरी को रिसेप्टर भी चाहिए, मतलब HIV ने GP120 के थ्रू CD4 रिसेप्टर से होस्ट सेल पे बाइंड कर लिया, पर HIV की एंट्री के लिए एक सेकेंड को रिसेप्टर भी चाहिए. यूजुअली द कीमोकाइन रिसेप्टर एक एज अ को रिसेप्टर. सो जो कीमोकाइन रिसेप्टर्स होते हैं वो एक्ट करते हैं एज अ को रिसेप्टर फॉर HIV एंड एक्ट बाय बाइंडिंग टू ग्लाइकोप्रोटीन 120. फॉर एग्जाम्पल्स ऑफ कीमोकाइन रिसेप्टर्स आर CXCR4 molecules present on T lymphocytes and CCR5 molecules present on cell of macrophage lineage. मतलब सेकेंड को रिसेप्टर भी हमें चाहिए होता है जिससे कि HIV की एंट्री हो जाए होस्ट सेल के अंदर. वो बाइंड तो हो गया CD4 रिसेप्टर जो होस्ट सेल पे प्रेजेंट था उससे, अब उसकी एंट्री के लिए एक हमें सेकेंड को रिसेप्टर भी चाहिए जो कि क्या होता है कीमोकाइन रिसेप्टर विच एक्ट एज को रिसेप्टर फॉर HIV. So examples are CXCR4 and CCR5. CXCR4 present on T lymphocyte, CCR5 present on the cells of macrophage lineage. Now in third point of pathogenesis is replication. Now after entering into the host cell, what does the HIV virus actually do? So as we know that HIV contains the two molecules of single stranded RNA which are positive sense. So here positive denotes to the sense of rotation. So single stranded RNA which is from HIV virus. Now the reverse transcriptase enzyme which is present in the HIV virus, it has an activity, it is RNA dependent DNA polymerase activity of reverse transcriptase enzyme. It means RNA dependent DNA polymerase means synthesis of DNA from RNA. So this enzyme is used reverse transcriptase which acts as a RNA dependent DNA polymerase enzyme. So by the activity of reverse transcriptase enzyme, it acts as RNA dependent DNA polymerase enzyme. It forms the DNA RNA hybrid. Now the second activity of the reverse transcriptase enzyme is the ribonuclease activity. First one is RNA dependent DNA polymerase. It is forming DNA from RNA, DNA RNA hybrid from RNA. Now second, it is having ribonuclease activity of reverse transcriptase enzyme. Means it perform digestion and form the single stranded DNA. Digest the one strand and form the single stranded DNA. Now the third activity of the liver transcriptase enzyme. So all these three activities are performed by the liver transcriptase. Means it acts as different types of enzymes. For example, firstly it was acting as a RNA dependent DNA polymerase. Secondly, it was performing ribonuclease activity. Now third, DNA polymerase activity of liver transcriptase enzyme. Now due to this, it forms the double-stranded DNA. Now this double-stranded DNA is transported into the host cell nucleus. Means the virus is outside the nucleus. It is inside the host cell but outside the nucleus. Now when the double-stranded DNA is formed, then it is transported into the host cell nucleus. Now the other two exams are integrase and protease. So integrase will come into the role. Now after entering into the host cell nucleus, this viral integrase with the help of the enzyme viral integrase, the double-stranded DNA gets integrated into the host chromosome. Now the host cell contains its chromosomes. This double-stranded DNA with the help of viral integrase gets integrated into the host chromosome. Now this double-stranded DNA undergoes transcription. Normally in host cell, means let's talk about humans. In humans, the synthesis of synthesis of RNA from DNA takes place. It is known as transcription. So it is normal process that is occurring in the host cell. The synthesis of RNA from DNA, transcription, that is host RNA by the help of host RNA polymerase. Then it forms the mRNA. Now this mRNA, by the help of translation, form the viral proteins because it contains the double-stranded DNA that is which is formed by the virus. So the proteins which are forming are viral proteins as a result of translation. And this double-stranded DNA, by the help of host cell polymerase, also form the single-stranded RNA. And these two combine to form an assembly called titer variants. So this is the process how the single-stranded RNA of the HIV virus form the daughter viruses inside the host cell. Now let's talk about the clinical diagnosis. Now in clinical diagnosis of AIDS, according to WHO, the World Health Organization, the WHO has divided the clinical staging of HIV and AIDS into the 4 stages. Now in clinical stage 1, the infection is generally asymptomatic, means asymptomatic HIV infection. Generally asymptomatic, but there is a in stage 1 persistent generalized lymphadenopathy, means presence of enlarged lymph nodes in more than 2 or 3 contiguous places, greater in size more than 1 centimeter. Now this persistent generalized lymphadenopathy should not be confused with the lymphadenopathy due to lymphoma. So persistent generalized lymphadenopathy is the presence of enlarged lymph nodes that is greater than 1 centimeter in size in more than 2 or more contiguous places in the body. Now why the lymph nodes get enlarged? As we know, the HIV virus causes the destruction of T helper cells. Now it resides inside the lymph nodes and multiplies. So the lymph nodes becomes enlarged as a result of destruction. Now the clinical stage 2 according to the WHO is, first one is unexplained moderate weight loss. That is less than 10% of the body weight. अगर किसी का weight 100 kg है और एकदम से 90 kg हो जाए unexplained without any reason, मतलब कोई पर्सन एक्सरसाइज भी नहीं करता है तो फिर वो अपना नॉर्मल रूटीन फॉलो करता है, कोई ऐसा चेंज नहीं कर रहा, ना डाइट चेंज कर रहा है, ना रेगुलर फिजिकल एक्टिविटी चेंज नहीं कर रहा, फिर भी उसका अनएक्सप्लेन वेट लॉस हो रहा है, जिसमें कि कोई और अदर कंडीशन इन्वॉल्व नहीं है। फॉर एग्जांपल हाइपरथर्मिया, उसमें वेट लॉस होता है, वो भी अदर देन अनएक्सप्लेन है ना, कोई और कंडीशन नहीं होनी चाहिए। तो अनएक्सप्लेन मॉडरेट वेट लॉस लेस देन 10%, और रिकरेंट रेस्पिरेटरी ट्रैक्ट इन्फेक्शन, साइनोसाइटिस, टॉन्सिलाइटिस, ओटाइटिस मीडिया, फेरिंगाइटिस। अब ये रिकरेंट रेस्पिरेटरी ट्रैक्ट इन्फेक्शन हम क्लिनिकल स्टेजेस में हम देखेंगे कि ये सब इन्फेक्शन हो रहे हैं, डिजीजेज हो रहे हैं, तो यही होती है अपॉर्चुनिस्टिक इन्फेक्शन। अब HIV करता है क्या? HIV CD4 सेल्स पे अटैक करता है, T हेल्पर सेल्स पे अटैक करता है, मैक्रोफेजेस पे अटैक करता है। अब ये सारी सेल्स हमारी बॉडी में इम्यूनिटी के लिए रिस्पॉन्सिबल होती हैं, इम्यून रिस्पॉन्स के लिए रिस्पॉन्सिबल होती है, जो कि क्या करती हैं, किसी भी डिजीज़ कॉजिंग ऑर्गेनिज्म से, उसके एंटीजन से ये लड़ती हैं, हमें इम्यूनिटी प्रोवाइड करती हैं, जिसकी वजह से हमें जनरली ये सब डिजीज़ नहीं होती। फॉर एग्जाम्पल ट्यूबरक्लोसिस द मोस्ट कॉमन डिजीज सीन इन द HIV पेशेंट। जनरली ये डिजीज़ नहीं होती बिकॉज ऑफ आवर इम्यून सिस्टम, इम्यून रिस्पॉन्स। बट इन HIV individuals this immunity becomes very low, hence the name acquired immunodeficiency syndrome. So because of the immunodeficiency there are recurrent respiratory tract infection, recurrent fungal, viral, parasitic. So these are the opportunistic infection, that's why it is called as syndrome. तो herpes zoster, रिकरेंट herpes zoster सही होता है, फिर हो जाता है herpes zoster। एंगुलर चेलाइटिस, रिकरेंट ओरल अल्सर्स, पेपुलर प्रोराइटिक इरप्शंस, बॉडी पे पेपुलर प्रोराइटिक इरप्शंस होते हैं, सेबोरिक डर्मेटाइटिस, फंगल इन्फेक्शन दैट इज ओनाइकोमाइकोसिस। नाउ द क्लिनिकल स्टेज 3 ऑफ WHO, it is a stage 3. In stage 2 we have seen that it is unexplained weight loss less than 10%. In clinical stage 3 it is unexplained severe weight loss greater than 10%, means the weight loss is greater than 10%। अचानक से किसी का वेट 10% से ज़्यादा कम हो गया, फॉर एग्जांपल किसी का 100 kg वेट है, अचानक से 70 हो गया, 60 हो गया, एंड बिकॉज ऑफ अनएक्सप्लेन, उसका कोई रीज़न नहीं है उसको मिल रहा, तो अनएक्सप्लेन वेट लॉस। अनएक्सप्लेन क्रॉनिक डायरिया, अनएक्सप्लेन persistent fever more than 1 month. So these three are the important symptoms which you will also find in the clinical questions. These three will be mentioned, which is unexplained severe weight loss more than 10%, unexplained chronic diarrhea for more than 1 month, unexplained persistent fever for 1 month, oral candidiasis, oral hairy leukoplakia occurring on the sides of tongue, टंग की साइड्स पे अब वाइट पैचेस टाइप के फॉर्म हो जाते हैं, इट इज़ ओरल हेयरी ल्यूकोप्लेकिया। पल्मोनरी ट्यूबरक्लोसिस द most common disease which are found in the HIV patients, pulmonary tuberculosis, and severe bacterial infection, for example pneumonia, emphysema, acute necrotizing ulcerative psoriasis, gingivitis, periodontitis, and unexplained anemia, and it is loss of blood. It is unexplained anemia means less blood, neutropenia, low neutrophil count, or chronic thrombocytopenia means platelet count decreases, platelet count decreases very much, neutrophil count decreases very much, neutropenia. And unexplained anemia means less hemoglobin, low hemoglobin, unexplained anemia, neutropenia and chronic thrombocytopenia. किसी को अनएक्सप्लेन रीजन से एनीमिया हो रही है, न्यूट्रोपीनिया, उसकी न्यूट्रोफिल्स कम हो रही हैं, थ्रोम्बोसाइटोपिनिया, प्लेटलेट कम हो रही है, सो इट कैन बी HIV. नाउ द क्लिनिकल स्टेज 4, इसमें क्या होता है, HIV वेस्टिंग सिंड्रोम, दैट इज स्लिम डिजीज़ मतलब पर्सन देखने में एकदम पतला दुबला होगा, कमज़ोर होगा, मीन्स उसकी हड्डी दिख रही होंगी, दैट इज HIV वेस्टिंग सिंड्रोम, which is characterized by profound weight loss more than 10%, chronic diarrhea for more than 1 month, and prolonged unexplained fever. And there are bacterial opportunistic infection, for example, recurrent severe bacterial infections, which we have studied, otitis media, sinusitis, pharyngitis, extrapulmonary tuberculosis. Now, pulmonary tuberculosis, the extrapulmonary tuberculosis means the tuberculosis will be occurred in various other different organs, for example, brain TB or skin TB and other forms of TB. Disseminated non-tubercular mycobacterial infection, recurrent septicemia including non-typhoidal salmonella, and viral इन्फेक्शंस की अगर बात करें, वायरल अपॉर्चुनिस्टिक इन्फेक्शन, फॉर एग्जांपल क्रोनिक हर्पीज सिम्प्लेक्स वायरस इन्फेक्शन और प्रोग्रेसिव मल्टीफोकल लिक्योएन्सेफेलोपैथी, साइटोमेगालोवायरस रेटिनाइटिस और इन्फेक्शन ऑफ अदर ऑर्गन्स, इट इज CMV रेटिनाइटिस, फंगल अपॉर्चुनिस्टिक इन्फेक्शन, वेरी कॉमन न्यूमोसिस्टिक जीरोविसाइन निमोनिया, esophageal candidiasis or oral candidiasis, which we have discussed in other clinical stage, extrapulmonary cryptococcosis, that is meningitis, cryptococcal meningitis, disseminated mycosis, that is histoplasmosis, coccidioidomycosis. Now the parasitic opportunistic infection contains toxoplasma encephalitis, which is caused by Toxoplasma gondii. Toxoplasma encephalitis, chronic intestinal cystiosporis for more than 1 month, atypical disseminated leishmaniasis, which is caused by Leishmania donovani, or neoplasia. Neoplasia means like a cancer, Kaposi sarcoma, invasive cervical cancer, lymphoma, which can be cerebral, B cell lymphoma, or non-Hodgkin's lymphoma. Other conditions that are direct HIV induced, which are induced directly by HIV virus, means, for example, the parasitic infection like Toxoplasma encephalitis was caused by Toxoplasma gondii, but direct HIV induced conditions are HIV encephalopathy और symptomatic HIV associated neuropathy और कार्डियोमायोपैथी. मतलब डायरेक्ट HIV वायरस जो है हमारे नर्व्स पे इफेक्ट डालता है, कॉजेज सिम्टोमेटिक HIV एसोसिएटेड न्यूरोपैथी और HIV एसोसिएटेड कार्डियोमायोपैथी, हार्ट पे भी असर डालता है डायरेक्टली. Now opportunistic infections, we have seen so many opportunistic infections which happened in HIV infected individuals. Now globally, including India, tuberculosis is the most common opportunistic infection that occurs in HIV infected individuals. As I have told you that tuberculosis is the most common opportunistic infection. Common fungal infections are candidiasis, that is oral thrush, pneumocystis jirovecii, pneumonia. Frequent viral infections are herpes simplex, mucosal lesions, and CMV retinitis. Common parasitic infections are Cryptosporidium parvum diarrhea, it is diarrhea due to Cryptosporidium parvum parasite, and Toxoplasma encephalitis due to Toxoplasma gondii, and Stangolite stercoralis hyperinfection syndrome. So these are the main opportunistic syndrome and WHO. So these are the main opportunistic infections in HIV patients. So there are two graphs given. Let's understand these graphs. So in y-axis the CD4 T cell count is given, and on x-axis the time is given. So as you can see, during primary infection, the normal CD4 count is between 500 to 1500 cells per microliter. The normal CD4 count is in a normal individual 500 to 1500 cells per microliter. So during primary infection, when the count was normal in the patient, that is given 1000. Now, as the disease progresses, you can see the CD4 count is rapidly or progressively decreasing, that is declining. Now the CD4 cell count per mm cube related to various opportunistic infections. The opportunistic infections occur due to immune deficiency or decrease in the CD4 cell count. So as our CD4 cell count start decreasing, the opportunistic infections start occurring in the patient. For example, the CD4 cell count of 500, the associated opportunistic infections most common at this CD4 count are bacterial skin infections, herpes simplex virus, fungal infection. At count 400 is Kaposi sarcoma, 300 CD4 cell count is hairy leukoplakia or tuberculosis, and when the count goes to 200 it is cryptococcosis, toxoplasmosis, and when the count goes below the 200, the CD4 cell count when goes below the 200 cells per mm cube, it is known as AIDS. Now we can say that the disease has progressed into the AIDS, acquired immunodeficiency syndrome. Now the syndromes is now it is progressed to the acquired immunodeficiency syndrome. Now let's discuss the lab diagnosis. So the screening test means the screening test what now let's discuss the lab diagnosis of the HIV. If anyone suspect that he or she have a HIV, then how to diagnose, which test to perform, and what is the basis and the principle of the test. So first are the screening test. That is, they detect the antibody. Sensitivity is more than or equal to 99.5% and are specific. That is more than 98%, having specificity, and sensitivity is much better, it is 99.5%. Now the screen test includes ELISA, that is enzyme linking immunosorbent assay. Now the ELISA, which is a screening test, it is an enzyme linked immunosorbent assay. It is a screening test. It takes 2 to 3 hours. Now the ELISA is of two types: third generation ELISA and the fourth generation ELISA. Of course, fourth generation ELISA is better than the third generation ELISA. So in third generation ELISA, it detects HIV antibodies from the serum. But in fourth generation ELISA, it detects both HIV antibodies and the P24 antigen. So it is a better test, better ELISA, better type of ELISA. It is the fourth generation ELISA. Now let's talk about the type of ELISA: indirect ELISA, competitive ELISA, and sandwich ELISA. These are the types of the ELISA. Now the second screening tests are rapid and simple tests, which takes less than 30 minutes to diagnose. For example, the dot blot assays or immunoconcentration or flow through method. For example, tri-dot test. Second one is immunochromatography or ICT or lateral flow assay. Third one is particle agglutination assay, that is using latex, gelatin, and RBC. Dip sting or comb test, that is enzyme immunoassay based test. So these are the rapid and the simple tests which takes less than 30 minutes to diagnose if the patient is having or if the person is having HIV or not. Antigens used in most of the screening tests are now what antigens are used in these screening tests. So HIV one specific, as we know that HIV is composed, HIV have two serotypes, HIV 1 and HIV 2. Now these tests detects which antigen. HIV 1 specific antigen is P24, GP120, GP160, and GP41. This GP160 forms that is cleaved into GP120 and GP41. So it detects also GP120, GP41, and their product and their combined product is GP160 and P24 also. HIV-2 specific GP36, which is specifically this antigen is found in HIV-2 type of serotype. If a person is infected with the HIV-2 type of serotype, then the antigen that will be detected by these tests is GP36. They detect HIV 1 and 2 either separately or together. Either they will detect the HIV 1 or 2 together or separately. Now the supplemental test, which also detects antibody. First one is Western blot assay. It is the most commonly used supplemental test and it is also recommended by NACO. What is NACO? National AIDS Control Organization. This test is also recommended by NACO. It is Western blot assay, most commonly used supplemental test, also recommended by NACO. It works on the principle of immunoblot technique. So what is the principle of Western blot assay? We can say it is a works on the principle of immunoblot technique. It detects individual antibodies in serum separately against various antigenic fragments of HIV. मतलब वेरियस एंटीजेनिक जो फ्रेगमेंट्स होते हैं HIV, जैसा कि हमने देखा HIV-1 स्पेसिफिक, GP120, GP41, GP160, वेरियस एंटीजेनिक फ्रेगमेंट्स को ये इंडिविजुअल उनके अगेंस्ट इंडिविजुअल एंटीबॉडी डिटेक्ट करती है सेपरेटली. So this is the basis of Western blot assay. It is a supplemental test, antibody detection test, most commonly used supplemental test recommended by NACO, works on the principle of immunoblot technique and detects individual antibodies in serum separately against various antigenic fragments of HIV. The antigens we have discussed, HIV-1 specific or HIV-2 specific. Now the confirmatory test. Now if the screening test, now this is the strategy of NACO. So if the screening test of an individual is positive, then it is not assumed that the person is having HIV or is a HIV patient. It should be confirmed with the confirmatory test. It is very important, it is necessary, and it is a rule that the screening test result should be confirmed with the confirmatory test. So confirmatory test consists of P24 antigen detection. This test becomes positive after 12 to 26 days of infection, but it is less sensitive. It is 30% having sensitivity. But the screening test results should always be confirmed by the confirmatory test. For example, P24 antigen detection. It should not be assumed. If the screening test result is positive, then it should not be assumed that the person is HIV positive and the person is HIV patient, or we should hand over the report to the person or say you are HIV positive, go and start the treatment. No, but first it should be confirmed by the confirmatory test. Uses of P24 antigen detection test for confirmation of diagnosis of HIV or AIDS. Diagnosis of HIV during the window period means window periods of HIV is between 3 to 12 weeks, means the entry of the virus into the body and the appearance of the symptoms or appearance of the detectable amount of antibodies. It is called the window period. Means the time period between the exposure of the infection and the appearance of detectable amount of antibodies in the serum is called the window period, which is 3 to 12 weeks in HIV. So diagnosis of HIV during the window period can be performed by P24 antigen detection, and it can also be used to diagnose the late state of HIV/AIDS, that is immune collapse or CNS disease. Means if the HIV is already have progressed to AIDS, then the P24 antigen detection test can be performed. Diagnosis of HIV in infants. It can be done but is generally not reliable. Monitoring the progress of HIV infection. So monitoring the progress of HIV infections mean if suppose we are giving the antiretroviral drugs to the HIV infected patient, then we can perform the P24 antigen detection test for monitoring the progress of HIV infection, if our ART therapy, antiretroviral therapy is working efficiently or not. But the monitoring the progresses of HIV infection, there are better ways. which are CD4 cell count or HIV RNA. Better ways to monitor the progress of HIV infection is by CD4 cell count or HIV RNA, but it can also be monitored by P24 antigen detection or to resolve equivocal Western blot results. Means if the Western blot results, if we have performed the Western blot result in person and it is positive, the second time we perform the Western blot result, it is negative. Now the results are equivocal, means it is positive also, negative also. It is indeterminate. We can't say anything. To resolve that equivocal Western blot results, we can use the P24 antigen detection test. Now the second confirmatory test is HIV RNA test. It is the best confirmatory method, can be detected 10 to 14 days after infection. So it is the call as the gold standard test. Now the detection of HIV virus, the detection of HIV RNA, it is the best confirmatory method. It is the best confirmatory test, and the HIV RNA can be detected from 10 to 14 days after the infection. So it is the gold standard type of confirmatory test. Means it is the most important and the best confirmatory test. Now the ways to find the HIV RNA is by through RT-PCR, liver transcriptase PCR, branch DNA assay, through NASBA, nucleic acid sequence based amplification, real-time RT-PCR for estimating viral load, HIV DNA detection useful for diagnosis of pediatric HIV. Now, as we have discussed that P24 antigen detection can be used to diagnose neonatal or infantile HIV/AIDS, but the best method is to diagnose pediatric HIV is HIV DNA detection. So these are the 5 ways by which HIV RNA can be detected, and this HIV RNA detection is the best confirmatory method. Why? Because it is a because it is the most sensitive and specific method, detects even few copies of viral RNA. If the viral RNA copies are very few, then these can also be detected by the HIV RNA test, and is the best method for confirmation of HIV as we can study. It is the best tool for the diagnosis of HIV during window period. Now during the window period we have discussed P24 antigen detection is also useful, but the best tool to diagnose HIV during window period is HIV RNA through RT-PCR. Detects HIV earlier than all available method. It is 10 to 14 days post exposure. After the exposure infection of HIV, after 10 to 14 days it can detect. Even though the viral RNA is very few, it can detect during the window period also. Viral load monitoring, real-time RT-PCR can quantify the viral load and the most appropriate tool for monitoring the response to antiretroviral therapy. Now, as I have told you, for monitoring the progress of HIV infection or monitoring the response to antiretroviral therapy, we can perform two methods, either by counting the CD4 cell count or by performing the HIV RNA load by RT-PCR. Typing RT-PCR can successfully differentiate between HIV-1 and HIV-2 infection and can detect the specific genotype or subtype. Now the HIV virus has two serotypes, as we already know, HIV-1 and HIV-2. This RT-PCR can also successfully differentiate between the HIV-1 and HIV-2. So these are the cons of HIV RNA detection as compared to P24 antigen detection. Now the prognosis of monitoring of HIV we can perform by CD4 T cell count, most commonly used, HIV RNA load, most consistent and best tool. The best tool is HIV RNA load for monitoring the prognosis of, for monitoring of HIV and P24 antigen detection. Now, as we have discussed the topic HIV/AIDS, Let's solve some multiple choice question to clear our concepts. Now the first MCQ is the gene coding for the core of HIVs. Now which genes code for the core of HIVs? Now we do know. Now we know that there are three structural genes. Three structural genes and six non-structural genes. These three structural genes are GAG, POL and INV. Now we know, as we have studied, that GAG genes code for the core or the shell of the enzymes. POL genes code for the now, now as we know that the GAG gene codes for the core or the shell of the HIV. POL gene codes for the different enzymes, river transcriptase, integrase, protease. The N gene codes for the envelope, that is the glycoprotein 120, which is a part of the envelope, glycoprotein 41. So the question is asking gene coding for the core of HIV. So it is GAG gene, structural gene. Second question is, during the window period of patient with AIDS, best diagnosis test is, means during the window period of patient with AIDS, best diagnostic test is. So this we have studied recently, that it is RT-PCR. We can find the we can diagnose the AIDS during the window period by P24 antigen detection also, but it is not the best method. The best method is by through RT-PCR by detecting the HIV RNA. This is the best method. Now the third question is best indicator of HIV prognosis. Now if we are giving patient antiretroviral therapy, if a patient is on antiretroviral therapy, generally the TLD regime is preferred. TLD means tenofovir 300 mg, lamivudine 300 mg or dolutegravir 50 mg. Now this TLD regimen is used by NACO, this antiretroviral therapy. It is a nucleotide river transcriptase inhibitor, and it is a nucleoside river transcriptase inhibitor. It is a integrase inhibitor. So for monitoring the HIV prognosis or monitoring the effect of antiretroviral therapy on patient, which is the best indicator? CD4 T cell count, CD8 T cell count, HIV RNA or ELISA? But the best indicator is CD4 T cell count, because it is a directly related to the HIV infection, as we have seen how the CD4 cell count was decreasing and was associated with the various symptoms. So it is directly related to the prognosis or status of HIV infection. So it is the best indicator. It is a CD4 T cell count. So our fourth question is higher risk of transmission of HIV. Highest risk of transmission of HIV. Options are sexual, blood products, needle syringe or mother to fetus. So in sexual, as we know, it is the most common mode of transmission. More than 75% cases are of due to sexual unprotected sexual intercourse. But the risk is minimum 0.1 to 1%, as we have seen in the table. So not sexual. The higher risk of transmission is by blood products. That is more than 90%. It is having a higher risk of transmission. Through mother to fetus, it is 20 to 40%. Through needle to syringe, it is 13 to 18%. So the answer is higher risk of transmission of HIV is by through blood products. Now the fifth MCQ is, after HIV infection, antibodies are undetectable for a period up to. HIV के इन्फेक्शन होने के बाद कितने टाइम तक एंटीबॉडीज़ अनडिटेक्टेड रहती हैं लगभग, है ना. इसी को हम विंडो पीरियड भी बोलते हैं जब HIV को हम डिटेक्ट नहीं कर सकते. तो आफ्टर HIV इन्फेक्शन एंटीबॉडीज़ आर अनडिटेक्टेबल फॉर अ पीरियड अप टू, सो वी नो विंडो पीरियड ऑफ HIV AIDS is, it is 3 to 12 weeks. Means up to 12 weeks. 12 weeks means up to 3 months. The detectable amount of antibodies are not present in the patient's serum. So it is, the answer is third one. So thank you everyone. So if you like the content, then like this video and subscribe the channel for more such informative videos. So keep on watching and